The following is an exclusive presentation of Optimum Local. It's Optimum or it's not.
Congestive heart failure, or CHF, affects 5 million people in the United States. It's the most frequent reason for rehospitalization.
But great strides are being made by our local community to reduce hospital readmissions for patients who suffer from heart failure.
It clearly takes a village. You'll see on this week's Health Talk.
We're up next. Welcome to Health Talk. I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. Today we're going to talk about a community collaboration effort aimed at reducing patient readmissions to the hospital from patients who have congestive heart failure, CHF.
Our guests on the first segment are Dr. Louis Berman. He's the chairman of the Norwalk Hospital Department of Medicine. And also joining us is Joanne Svogen. She's the patient care director.
Welcome back to Health Talk.
Welcome, both of you.
Thank you.
So, Lou, we're talking about congestive heart failure, but really we're talking essentially about what's going on in healthcare throughout the country, aren't we?
That's right, Andrea. I think as you look at healthcare throughout the country, the focus has shifted from just being on the hospital, where we've done a lot to try to improve the quality of care, not just try, but to succeed, but to look at the patient both in the hospital and out of the hospital, trying to keep patients out of the hospital who don't need to be there, and for patients who do need to be in the hospital, trying to make sure that they get the right care when they leave the hospital, whether it's at a skilled nursing facility, visiting nurse, or home with no services, so that they can be healthy and get back and get better and be independent again.
So this is a totally new way of thinking about our responsibility. Everybody sitting in the room here right now is hospital-based and hospital-oriented. And this is a whole new way of thinking about our responsibility in the care of our patients, isn't it?
It absolutely is, and it's something that the hospital is really excited about, because now we're going to take care of our patients not only while they're in the hospital, but we're concerned about what happens to them once they leave our doors. And this is a new paradigm for Norwalk Hospital and most hospitals. And we are concerned about where they go after they leave. Are they going home with home care? What home care agency are they using? And is the home care agency going to be following what the guidelines are for whatever particular diagnosis, in this case CHF, whether they go to a skilled nursing facility. So we have a wonderful collaborative effort at Norwalk Hospital with all of these different agencies in order to be able to take the best care of our patients as we move forward.
So maybe we could start with CHF, congestive heart failure, and why this was a target. Maybe Lou, as a doctor, just a couple of words about what it is and why it should be a focus for this kind of an effort.
Sure. Congestive heart failure, or CHF, is when the heart doesn't beat blood strongly enough. So what happens is the fluid can back up into your lungs and it makes patients short of breath. They can develop swelling. The thing about congestive heart failure is it's not just about the doctor giving you the right medicine. It's about taking the medicines, but it's also about doing things behaviorally to help keep yourself from getting into trouble. It's about eating the right foods, avoiding salts. It's about watching your weight so that if you start to get into trouble, you can get help before it gets out of control.
Right, it's a chronic disease. Once you have it, you basically have it, and it can be properly managed and keep people pretty functional, right, Joanne?
Correct, and I think one of the biggest things that we've learned is that patients who have this chronic disease really have to understand it in their own terms. And one of the things that we did was we developed, in collaboration with the outside agencies, an evidence-based education booklet that is done in language that patients can understand, and the education actually starts at the hospital. They then take this booklet with them to the next level of care, whether it's home care or whether it's within a skilled nursing facility, so they're getting the same training no matter where they are. And that helps them remember what they need to remember.
And the education is so important, but I also want to focus on something you said. You said in collaboration with outside agencies. Tell us a little bit more about that, because that's key to all of this.
Absolutely, and one of the things we realized early on is that whatever we did in the hospital would be great, but the patient doesn't live at Norwalk Hospital. And they need to be able to hear the same information from whatever provider they're having, including their primary care physician. And so in collaboration with the home care agencies and the skilled nursing facilities in our area, we developed a book that we really felt was evidence-based and that would help the patient understand their disease.
And everybody worked on developing this. I
Correct.
know the skilled nursing facilities, or the nursing homes, as well as the home health agencies.
Correct.
Everybody had their input.
That's right.
And I can't stress how important that is, because we often give patients advice but use different words and think we're saying the same things, but patients and families often hear different things if we use different words, so they were getting different messages. And so what's really important here is that we're going to have a consistent way to convey the information so that when they hear it from the hospital folks or the folks in the community, they'll be getting the same message and hopefully won't get confused.
And I think one of the things Lou just said is about the patient and family. We all know that patients, when they're in the hospital, are not feeling their best, and hearing information at that time, they may not remember everything. But one of the things we decided as a group was that we were going to determine a care coach, and that's a sibling or a daughter, son, husband, wife, who will also hear the same information, so they'll be able to carry that forward with them to the next level of care.
So when you say that, you mean when a patient with congestive heart failure comes into the hospital, somebody identifies their specific care coach. And again, this is not a professional, this is a family member or someone very close to the patient.
Correct. That's exactly right. So that person can hear the same information, and then whatever the patient doesn't remember, the care coach will, or vice versa. And that way, they really begin to understand their disease process.
And Lou, as a doctor, we are talking a bit about reducing hospital readmissions, but it's really about helping patients live their lives with doing everything they want to do, living their lives in as great health as they can with minimal symptoms and feeling well.
Exactly. As Eric said, this is a chronic disease. It's a disease that's with them all the time. But if you manage it appropriately, you're going to feel the best you can feel and be able to live the most out of life. And so what we're really trying to do is marshal all the support from both the patient and the community so the patient can feel the best they can feel and not have to be worried that they're short of breath all the time or they're just a stone's throw away from the hospital.
Because again, we can do a lot of great things in the hospital, but if patients and families don't have the follow-up they need, can't help themselves in knowing what to do, they can lose the gains that they achieved in the hospital.
That's right, and that's often frustrating to us in the hospital because we get somebody to the point where they're ready to be discharged, and lo and behold, they're back a week or 2 weeks later, and we're like, well, what can we do better? And the answer is, an individual physician, nothing. You've done everything right. Unless you have this whole system set up, that patient's going to be back despite your best efforts. So not only is the patient frustrated, the caregivers are frustrated too, because we don't want to see this person back because we want them to be healthy in the community.
And what I'm so excited about this as a physician, as somebody who's cared about health my whole life. This is a whole new way of thinking about our responsibility as healthcare providers. You mentioned several things have been mentioned, but I think they're worth emphasizing. You mentioned tying what happens in the hospital back to people in the community, the patient's primary care physician, their skilled nursing help, nursing homes, all being on the same page. But you also mentioned something else, and that is the patient's own involvement. We're beginning to understand that the healthiest patients are patients who are involved, invested, understand their own health care. So if you could say a few words about that, because it's a whole new way of thinking, and I know we even have some special methods we're using to teach patients.
Correct, and I think that's key, because as Lou had said, it is a chronic disease that you're going to have forever, but it definitely is manageable. And so we actually trained 40 nurses on our telemetry unit in what's called the teach-back method. And that method of education is actually giving the information to the patient at a level they'll understand, but not saying, do you understand? And everybody's saying, oh yeah, I understand. What it actually is doing is saying, tell me what I just told you, so that you know when they give the information back what they understood and what they didn't understand. So you can really focus on the parts that they don't understand. And that's the same method that the home care agencies and the skilled nursing facilities will be using, so that the patient will really get to understand their diagnosis as they move forward. And it's very exciting.
The point I want to make is that it's not just teamwork from within the hospital to outside the hospital, but it's even teamwork within the hospital. So we have our pharmacists coming by and teaching the patients about their medications using the same materials. We have our nutritionists coming by and teaching the patients about the dietary things that they need to understand. So we really try to mobilize a team that's within the hospital as well as outside the hospital.
And again, making sure everybody on that team is speaking to the patient and their families in a consistent way, so the information that is the same sounds the same, so it can be reinforced.
Correct. And I think the other thing that we've done is we've developed a position called a transition coach. And this individual in the hospital actually is the person that reaches out to the community. They know the patient when they're in the hospital.
What do you mean reaches out to the community? Be a little bit more specific for folks
What
at
I mean
home.
is they actually have conversations with the visiting nurse that the patient is going to, the skilled nursing facility, telling the facility that this is the congestive heart failure patient, that they're going to be coming with their booklet so they're prepared when the patient gets there. And if there's any issues that the facility has or the home care agency has, they'll get back to this individual so we can strategize on how to fix whatever issue it is. We also make discharge phone calls to all of these patients. Our pharmacist calls the patient, makes sure they understand their medications. That's usually the biggest issue patients have. And it helps us understand what worked well, what didn't work well, so that if we need to make changes, we can make changes as we go along.
And I know there's one other thing that we've implemented, and again, this is not, we didn't invent it at Norwalk, this is something of best practice around the country, but we actually make sure the patient has an appointment, a follow-up appointment with their outpatient, either primary care physician or cardiologist, within a very short time of discharge from the hospital. Why is that important, Lou?
Well, again, as we talked about, such an important part of congestive heart failure is modifying medications and making sure the patient's following through with what they're supposed to do. And we know that the data shows that if you see your physician, you have the opportunity to adjust the medicines, but also make sure the patient is doing all the other lifestyle things that they need to do to be a participant. One of the things we didn't mention is we actually send the patients home with scales, because it's important that patients weigh themselves. And we want to make sure they have the capability of weighing themselves. And one of the things we want them to bring to the doctor is their weights, so the physician can see, are the weights going up? That's a sign that they're holding on to more fluid and maybe soon getting into trouble.
So you mentioned transitions, Coach. Transition is really the issue. We are learning as doctors, as providers, that time when care switches from one group of providers to another is really a time when things fall through the cracks. Maybe, Joe, say a few words about that and how we're trying to overcome that.
Right, that's a really important point, because we know what happened to the patient while they're in the hospital. We know what we did to take care of them. We need to communicate that to the next care provider, whether it's a home care agency, a skilled nursing facility, because if they don't understand the medications they were on or how often the patient
Why is that so complicated? For sitting at home, I know people always think, geez, all you have to do is pick up the phone and say a few words, and that's communication, but it's really not that simple.
It isn't that simple, and it's because there's so many different people that provide care to a patient now. We have hospitalists in the hospital. They may have several different nurses, case managers. There's a lot of people that take care of patients when they're in the hospital, and all of that information has to be given to the next level of care. And it's really important as this transition person, the written information is also then followed up with verbal information, so that if there's any questions, even if it's written, sometimes you don't know the questions to ask. And so that this gives people an opportunity to ask those questions and get clarification that you may not always have on a piece of paper that you may get with the information on it.
And I think one of the most exciting things about a program like this, too, is it places the patient and the family firmly at the center of that team. So doctors are communicating with doctors, and we are talking with home care agencies, but we're also trying to do a better job of letting the patients and their care coach know exactly what they need to do to help stay healthy too.
We're trying to build a resilient system, so we do try to do it all. We educate patients and their families, and that's super important. But we're also trying to build a structure around them so that if they don't understand or they fail, that we can pick up the pieces and make sure that they don't end up back in the hospital as the only rescue for them.
And this is the beginning of what we hope is going to be a change for many, many diagnoses, since so much of what we care for is chronic disease right now. This is really the first step in a journey that's going to involve a lot more patients.
That's correct. And when we look at readmission to the hospital, we have many diagnoses where patients are readmitted, not just Norwalk, nationally. And so we're really trying to learn the lessons here that we can apply to many other diseases so that we can try to decrease readmissions across the board. Some patients are going to come back no matter what. There's nothing you can do to prevent it. But our goal is, wherever we can, to try to prevent that.
And this also saves healthcare costs and resources. So this is really a wonderful first step.
Very exciting.
When we come back, we're going to talk to people who actually on the other side of the transition, people from skilled nursing and home health care. But Andrea and I will be back after this break.
Don't go away.
first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
My name is Fernanda. I'm the wife of a teacher. Budget cuts affected my husband's salary, so I'm picking up some part-time work. We're doing everything we can to make sure our kids eat today. Tomorrow, I just don't know. Fernanda, how'd I do?
Well, I usually fold the underwear first.
I meant the acting, but good to know.
Play a role in ending hunger. Visit feedingamerica.org/hunger and find your local food bank.
How many trees in the cookie jar? 1, 2, 3, 4, 5, 6, 7.
The smallest moments can have the biggest impact on a child's life.
Go Dad, go Dad.
Take time to be a dad today.
Mom, can we get some ice cream?
Please, Mom, please.
No, we're having dinner soon.
Please.
You don't have to be perfect to be a perfect parent. There are thousands of children in foster care who will take you just as you are.
Welcome back to Health Talk. I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazur. We're back with Sharon Bradley. She's a Chief Executive Officer of Visiting Nurse and Hospice of Fairfield County, and Marissa Cardillo, Nurse Liaison of the Wilton Meadow Healthcare Center. So you represent the other side, the hospital and the non-hospital side.
So Sharon, tell us a little bit about the committee that has been formed, which really brought in many members of our healthcare community.
Right, Andrea. We have a wonderful group that's working. There are about 40 members on the committee that meets monthly at 7 a.m. at Norwalk Hospital.
That's real commitment. And I go.
Yes.
People really show up at 7 a.m.
Yes,
And
yes.
it's standing room only.
Yes, it is. Yes, it is. There are approximately 5 home care agencies represented there, 3 skilled nursing facilities, a complement of staff from Norwalk Hospital, including nursing, case management, registered dietitians, pharmacy, physicians. It really is a wonderful group, and together we have begun the work on this program on the heart failure continuum.
And Marissa, we're laughing a little bit about how everybody's there at 7, but it really shows how eager people are to come together and develop a program like this.
It's a phenomenal thing when you see it all come together, because here's the whole health team, the whole continuum of care working together to accomplish this one goal, which is to get these patients to buy into it, to work with you, to keep them out of the hospital. And it's just so invigorating to get to go and talk and bounce stuff off of each other, see what's going to work, what's not going to work, and then to start to implement it.
And I'll bet you a lot of our viewers are at home are saying, this is new? You haven't been doing this? But the fact is we haven't been doing this. And I've been in healthcare 35 years. I did my part, and then I sort of expected everybody else to do their part. But we never really worked together at this level, did we?
Right. I think that's what's been so wonderful about this particular project, that we together have focused on looking at the care for individuals and families, because families are experiencing heart failure as well, and develop things in the hospital, educational materials. There's a wonderful educational booklet that has been developed by the group that is used with patients who are admitted to the hospital, and then we can carry that same piece of information out into the community, so that the individual and the families are getting the same information, same documents. Oh yes, I recognize this book. That was given to me in the hospital. Yes, I remember this part, but I'm a little bit fuzzy on this part, so we can take that and work with people in the community.
And this has really been stimulated by some of the changes in healthcare payment. And there's a lot of political discussion about that, but I think generically the idea that we are paid and supported to keep patients well and to keep out of the hospital really is a wonderful thing, isn't it?
It absolutely is. Wilton Meadows had started a in-service where they actually have had family members come in with their new model of the right care right here and their TLC program, which is Think, Look, Communicate, so that we can identify the changes early on in the residents and to get them the right care and hopefully to prevent that rehospitalization.
I'm sorry, I was just going to make it clear in case some of our viewers don't know. So you are a nurse from a nursing home. I don't mean to, but
yes,
a skilled nursing facility. And Sharon, you handle largely patients who are at home and provide services to them. I just wanted everybody to understand why we believe we're talking about the full spectrum of care here.
And tell us, we talked in the first segment about the hope that this will be generalizable, so that eventually will include patients with other diagnoses. And do you see that happening?
Absolutely. I mean, a lot of our CHF patients have a ton of comorbidities, and you kind of see them go hand
other illnesses.
Other illnesses, and they generally go hand in hand. And if they're not taking care of their respiratory status as well as their heart status, then you're going to see, or their diabetes. So it's pulling all of that together, but it's starting with how to educate them and get them to buy into being compliant. And this whole thing with the care coach and teach back is phenomenal because it starts at the hospital. And when we've got an identified patient for the CHF program, I get the phone call because I do the hospital evaluations, and I will go and I will meet this patient, and I'm asking, who is the care coach?
Hospital?
Yes, I go, this is what my role is.
Explain to the people. So you come into the hospital from Wilton Meadows.
Wilton Meadows, and yes, before they get discharged. And the goal is to identify them early enough and have me at least see them and track them, because sometimes things happen, they don't come out as quickly as we hope. But to have me meet them, figure out who this care coach is, because that person is going to still be identified at the next point of care, and bring them into, and this booklet that was developed is a tool that is started in the hospital. We will continue it at the skilled nursing facility. We will talk about it for the discharge. We will coordinate with the home care agencies that are involved with this, and we will have the same continuum of care. When they get to the facility, tell me what you've learned so far. And that's your jumping off point, because as Joanne had said, a lot of times patients are ill and there's a lot we don't retain. So it might be starting all over again. It might be picking up where you left off. But it's that repetitiveness, and that's the part.
Consistency.
Yes, and that consistency of just doing it over and over again and then sending it off to the next person, because as they get home, that's where old habits take over, correct?
Sharon, from the standpoint of the patient who goes home but is getting services at home, how has this affected the services, the way you deliver services to the patient who is at home?
Yeah, it's been wonderful. Similar to, as Marissa described, we're called in a little bit earlier to see the patients in the hospital. And rather than waiting to the time of discharge, as it was in past practices and historically, frequently the discharge planner would call the home care agency and make a referral, which worked all well and good. But this wonderful program with the heart failure continuum, our liaison nurses, much as Marissa does, we will come into the hospital and actually see and meet the patient, meet their family member, and that's also comforting for the patient and family as well, to say, okay, this is the individual who's going to help me move from the hospital into my home. And when we think about home care, I think I always describe it as we translate what's been learned in the hospital or from the physician into the home. Because sometimes, particularly around medications, say a dosing schedule, meaning a particular time of day that a medication's administered in the hospital, may not be ideal in the home situation because of their other commitments and responsibilities. So home care nurses can work with the patients and more closely and identify a plan that will work for them, particularly around medication, weights, exercise, diet. We have contacts at the hospital now with the transition coach, who is really our liaison person from the hospital to all the community settings.
I think what
And
you're
that's been
saying
great.
is so important because it gets back to this concept that we have to make healthcare individualized to really make it work for the individual,
Yes.
don't we?
Yes, yeah.
And yet we need systems
Yep.
in place to make sure that we do consistent messages, consistent understandings of what we should do. It's much more complicated, I think, than people possibly realize at home.
One of the things that the task force has been working on over the past months is developing a care path, so that when we've identified these heart failure patients, we're following a day-to-day. Okay, this is where we should be. This is where we should be in education, monitoring the vital signs. Getting the nutrition part of it reinforced, continuing the education and the teach back, setting up that doctor's appointment, and stressing again the importance of keeping that appointment, and just to get all of that in place so that we can get them to the next stage to go home. And it's when they come to a skilled nursing setting, it's because they're not quite ready to go home. And we have a lot of the elderly that become deconditioned very quickly. So it's also working with them with the physical therapy, getting them comfortable in pacing themselves. That's a big word that we use with them. And people don't get that. They just want to do it all, and then they're exhausted. And you want them to be able to go home and return to a function or quality of life.
Let me ask you a question that you may not have an answer for, but as we mentioned, this is really the first time everybody's gotten together to coordinate, to discuss the care of a group of patients, the congestive heart failure patients. And it's also in many ways brought you from the nursing home and from skilled nursing services for the first time face to face with the cardiologists and the doctors caring for those patients. What were your biggest surprises, or what were the things that helped you understand, or what do you see now about the hospital side that you didn't see before? How has that informed your thinking about this? Really interested, because we really didn't understand each other's worlds particularly well.
Right, Eric.
And I'm saying that as a physician who works in a hospital.
Yes, and likewise. I mean, what has brought to me personally, being a member of the team and others in our agency, is really to step in the shoes of those people in the hospital in terms of the various processes and the procedures that pass through, and certainly just to get to meet people and put a name to a face. That has just been a wonderful opportunity, and to work with colleagues in other home care agencies. As Marissa talked about, the care path in skilled nursing facilities, our home care also as part of this endeavor. Several home care agencies came together and developed a consistent home care plan. So, and that was a big move on the part of all of us to say, okay, together we're all going to focus on the care of this group of patients and families, and let's put aside what may be some differences and come together around to the benefit of the patients. It's been
Marissa,
really
have you
great.
had any epiphanies that sitting around the table?
Being able to be in the hospital and to see them at the beginning and what's transpired and everything that's happened, again, face to face with the doctors, the people involved in the patient's care, that kind of makes you feel more as part of a team. Being able to then relay that information, having met with maybe the social worker who's been dealing with the family to see what maybe some of the barriers are going to be.
And what this really is I think what drives us all is this is really the best care for the patient.
It is.
And believe it or not, that's all we have time for.
Okay.
But I think this is such a wonderful step. And it's not just Norwalk Hospital. A lot of folks are focusing on this. Right. But it really is such a good thing for you and for us, because we're all going to be patients.
Thanks
I want to
so
thank
much.
Sharon and Marissa so much for coming on the show.
We'd also like to thank our guests, Dr. Louis Berman and Joanne Svogen, for being on the show as well.
And I'm Dr. Eric Mazer.
I'm Dr. Andrea Peterson.
We'll both see you next week on Health Thoughts.
Stay well.
Bye-bye.